Hello, good evening, us. Hello, good evening. Oh, please, sorry for keeping us waiting. I actually had a quite a busy day, and at a point in time, I don't know when the time skipped my attention. So sorry for keeping everybody waiting. I think we can, in the absence of any other thing we are waiting for, I think we can start. Was I hard?
Yes,
Hello.
sir.
Okay.
Okay, so good evening, consultants, senior registrars, and house officers. My name is Dr. Dalapo, and I'll be presenting femoral hernia today. Um, sorry. I'll be using this outline. I'm going to start with introduction, statement of surgical importance, the relevant anatomy, risk factors, pathology, clinical presentation, investigations, treatment, complications, prognosis, and then we'll conclude. As a way of introduction, femoral hernias occur when abdominal viscera or omentum passes through the femoral ring into the potential space of the femoral canal. They are relatively uncommon, but are an important problem due to their high rate of strangulation from their narrow neck. Femoral hernias, femoral hernia is an important surgical condition with high rates of incarceration or strangulation and intestinal resection. Therefore, correct preoperative diagnosis of femoral hernia and a strict operative strategy are important to reduce the mortality and morbidity associated with this condition. Femoral hernias account for approximately 5% of abdominal hernias. It's more common in women than men. I'll explain this later. It's commoner in the fifth and sixth decades. The female to male ratio is 2 to 1, and this incidence is even doubled in multiparous women compared to the nulliparous ones. It's more common on the right side, and 20% of the times it's bilateral. So we're going to be talking about the relevant anatomy. So we'll start by talking about the femoral triangle, which is a wedge-shaped area located within the superiormedial aspect of the thigh, of the anterior thigh. This is the femoral triangle here. It acts as a conduit, like for structures that are entering or leaving the anterior thigh. So the borders, this is the femoral triangle. The superior border is the inguinal ligament. The lateral border is the sartorius muscle, and then the medial border is the medial border of the adductus longus. The roof is the facial lata, and then the floor is made up of the iliopsoas muscle, the pectineus, and then the adductor longus muscles as well. The contents of the femoral triangle include the femoral artery, the femoral nerve, the femoral artery, and then the femoral vein, and then and all of these are contained, and then and as well as the femoral canal. All of these are contained within the femoral sheath. This is the femoral sheath, and this is the femoral canal on this medial aspect, or just beside the femoral vein, and it contains deep lymph nodes as well as lymphatic vessels, and an empty space. So the femoral canal is a rectangular shaped compartment located within the femoral triangle. It is the smallest and most medial part of the femoral sheath, as I showed previously. This yellow rectangular structure represents the femoral canal. It's quite tiny. It's about 1.3 cm long. The medial border is the medial border is the lacunar ligament. The lateral border is the femoral vein, this blue structure. Then the posterior border is the pectineal ligament, this purple one, and then the rigid pubic bone. The superior border is the inguinal ligament, and then on this superior border, there is an opening known as the femoral ring. through which this is what predisposes of people to getting femoral hernias. So the femoral ring is usually located at the superior border, and it is usually closed by a connective tissue layer known as the femoral septum. And it's usually pierced by the lymphatic vessels, which usually exit the canal. So the rigidity of this pectineal ligament and this pubic bone is what the predisposes hernias to strangulation. The femoral canal, as I mentioned earlier, contains lymphatic vessels which drain the lymph nodes, deep lymph nodes known as Ploquet's lymph nodes, and then an empty space. The empty space is what allows the veins and lymphatic vessels to distend to accommodate different levels of flow at different times. So we're going to move on to the risk factors. The risk factors include the female gender. Women are more, this hernia is commoner in women, and this has been attributed to wider pelvis, as well as, so a wider pelvis will mean a wider femoral ring, and this would predispose women to get femoral hernias. Pregnancy has also been found to be associated with reasons why women are more predisposed to femoral hernia. Pregnancy leads to long-term increased intra-abdominal pressure, which and then as well as the pregnancy-induced laxity of anterior abdominal wall muscles as well as ligaments. Also, anything that can cause raised intra-abdominal pressure like heavy lifting, chronic cough, chronic constipation, and so on. And then increasing age. This is usually due to the natural wear and tear and weakening of tissue and loss of elasticity as we grow older. Okay, so I'd just like to add that earlier I mentioned that femoral hernias occur more on the right side. The exact reason for this has not been explained, but some theories have attributed this to increase use of the right side than the left side, which has led to the natural weakening and loss of elasticity on that side, which now predisposes people to femoral hernias. So for the pathology, following increased intra-abdominal pressure as well as development of weak spots, the hernia usually passes downwards through the femoral ring into the femoral canal, and then it progresses forwards through the fossa ovalis, or the opening for the saphenous vein, and then in turn turns upwards towards the subcutaneous tissue as a result of the fusion of the superficial and deep fascia. So most of the time, the content of the femoral hernia is usually omentum and small bowel, but the colon, fallopian tubes, and ovaries have been reported. So diagnosis of femoral hernia is based on history, physical examination, and investigations. So for history, only 30% of patients are aware of the hernia before strangulation. About 40 to 50% of femoral hernia cases will present as an emergency, either in obstruction or strangulation. So the non-acute presentation is the clinic presentation where the patient describes pain or discomfort in the groin, and is usually mild and exacerbated by bending or lifting. There may be a small groin lump that may be mildly tender and usually not reducible. And the groin lump is not always present. For the acute presentation, they usually presents with symptoms of obstruction or strangulation, which could be vomiting, colicky abdominal pain, which is usually severe. Then there's abdominal distension, constipation, and then they may present with a groin lump that is irreducible and tender. And then with some symptoms of strangulation, the lump is very tender, the skin around the area is hyperemic or inflamed, and then signs of shock, hemodynamic instability. Okay. So physical examination, the examination depends on the presentation. For non-acute presentation, the general physical examination is usually satisfactory. But for acute presentation, the patient will present in obvious painful, most times obvious painful distress with signs of dehydration. Abdominal exam for it is for the femoral hernia is typically a groin swelling that is below and lateral to the pubic tubercle. It may be tender or reducible or irreducible, as opposed to the inguinal hernia that is usually superior and medial to the pubic tubercle. There's usually there may be an expansile cough impulse, but it's not usually present due to the narrow canal. The engorged sign, dilation of superficial epigastric or circumflex iliac vein due to compression. So for investigations, the diagnosis can be made clinically, but additional imaging is usually required, which will help to delineate the anatomy and then to assess for any underlying complication from the hernia, either obstruction or strangulation. Ultrasound scan usually help to confirm the presence of a femoral hernia, and abdominal X-rays would pick up bowel obstruction. CT abdominopelvic CT scan with contrast can confirm the presence of a femoral hernia, and then can assess for features of ischemia or bowel obstruction. So the differential diagnosis, I'm going to talking about the commonest one, which is the inguinal hernia. As I mentioned previously, the inguinal hernia will usually be above and medial to the pubic tubercle, while the femoral hernia usually lies below and lateral to the pubic tubercle. So for inguinal hernia, it's above the crease of the groin and below in femoral hernia. Most times, inguinal hernia is usually can be reduced completely, but the reverse is the case for femoral hernia. Cough impulse is usually present for inguinal hernias, but many do not have a cough impulse for femoral hernias. Other differentials include Safena varix, that's usually circular termination of the long saphenous vein. It will usually, sorry, I don't have a picture, but it will usually disappear when the patient lies flat. It's usually soft. There's presence of fluid trail, and then you'll see other signs of varicose veins on the lower limbs. And then when you auscultate, you will be able to hear a venous hum. Others include enlarged femoral, deep femoral lymph node. It's usually difficult to differentiate this. However, for a femoral aneurysm, there will be a femoral, an expansile pulsating mass. For psoas abscess, there will be a fluctuant swelling below the inguinal ligaments, but this is usually distinguished via an X-ray or ultrasound. So there are there have been other associations of femoral hernia. We have the Laguerre's hernia, when the hernia protrudes through the lacunar ligament. To your left, there are some pictorial representations of all of this. Then other ones include Serafini's hernia, which can occur behind the femoral vessel. There's also hydrocele of the hydrocele of femoral hernia. Most times the omentum is usually the content of the hernia. So the omentum in the sac will secrete fluid, which is usually now called hydrocele of femoral hernia. Others include Hesselbach's hernia, which occurs lateral to the femoral artery. And then Lawrence hernia, which is usually found in congenital hip dysplasia, and this occurs behind the femoral artery. So management of the patient depends on the presentation. It could be, if it's emergency presentation or non-acute or elective presentation. However, it's important for all femoral hernias to be managed surgically because of the high rate of strangulation. So for acute presentation, we have to resuscitate the patient before taking the patient to surgery using the ABCD approach. Most of the time, the airway and breathing is usually okay, but attention needs to be paid to the hemodynamic stability, the three tubes, the IV cannula for intravenous fluids, um, then to take samples to correct other forms of this electrolytemia, the NG tube, the nasogastric tube for decompression, then the the urethral catheter, the urinary catheter for monitoring urinary output. Patient is placed on intravenous fluids, view purpose, and then early broad spectrum antibiotics are initiated, and then analgesia. For those presenting electively, ideally the femoral hernia should be fixed within 2 weeks of presentation due to their high risk of strangulation. This cannot be overemphasized. The general principles for operation involves reducing the hernia, narrowing the femoral ring with sutures medially between the pectineal and inguinal ligaments or a mesh block. And if we remember the anatomy correctly, remember that the the femoral ring is surrounded by some important neurovascular structures. So care must be taken to avoid the femoral vein laterally. Options of surgery could be open or laparoscopic. So for the surgeries, there are three classical methods. The low approach, which is also known as the Lockwood approach, which is usually below the inguinal ligaments. The inguinal approach, the Lorteson's approach, which is usually through the inguinal canal, and then the high approach, the McIvidy's approach, which is mainly above the inguinal canal. So this is a pictorial representation of the incisions for the different approaches. B is the Lockwood approach. This is like just 1 cm below the inguinal ligaments across the most prominent parts of the femoral hernia, while the A represents the inguinal approach, which is just parallel to the inguinal ligament, but above, like 1 cm above, 0.5 to 1 cm above the inguinal ligament. Then McIvidy's approach is the vertical incision, which is represented by C. So for the Lockwood approach, an incision is made 1 cm below and parallel to the inguinal ligaments. An 8 to 10 cm incision is usually made. The skin and the normal dissection until you get to the you get to the sac. Then the sac is opened and then the contents are reduced. Then the sac is twisted and then cut until it's no longer visible above the femoral ring. The femoral ring is closed using non-absorbable suture. This Lockwood approach is usually ideal for an elective procedure. The advantage is that it's simple and it's direct and straightforward, but it has some disadvantages in that it's difficult to explore the bowels if they are obstructed. So that's why we said that it's ideal for an elective procedure. So these are the steps which I just described. The inguinal approach is the Lorteson's approach. The transversalis fascia is opened from the deep inguinal ring to the pubic tuber bone, and then the hernia is reduced by a combination of pushing and pulling from above and below. And then once the hernia, the contents are reduced, the neck is closed with sutures, and then a mesh may be applied. Although it was formerly advised for strangulated femoral hernia as well, this approach holds no particular advantages. So the high approach, a vertical incision is made in the lower abdomen, centered at the lateral edge of the rectus muscle. The anterior rectus sheath is incised and the rectus muscle is displaced medially. The hernia is reduced and the sac is open for careful inspection of the bowel. Then same thing, femoral head defect is closed with sutures or mesh. And this is the preferred technique in an emergency intervention due to easy access of compromised small bowel and for any resection if necessary. This is the pictorial representation of the high operation. So laparoscopic approach, we can use a total extraperitoneal repair or a transabdominal preperitoneal repair. Standard mesh is inserted, and then this is usually ideal for reducible femoral hernias. It's not ideal for emergency cases or for irreducible femoral hernias. So complications of the procedure could be early or late. Early includes seroma or hematoma formation, urinary retention. The wound can get surgical site infection, injury to surrounding structures during the procedure. Then late ones could be recurrence and then chronic neuralgic pain, neuropathic pain due to nerve injury or entrapment. The prognosis of this depends on the age of the patient. The older the patient, the worse the prognosis is. The risk of emergency repair for a strangulated hernia is 10 times higher, and many patients are 80 years or over. The overall operating mortality for strangulated hernias is 10%. Other coexisting medical conditions could influence the outcome, and the rate of recurrence is usually 10 to 20% is usually low. In conclusion, femoral hernias are relatively uncommon, but they have a high propensity towards strangulation. Efforts should be geared to repair the hernias electively because of high morbidity and mortality associated with emergency operations. Precise preoperative diagnosis is imperative, and surgeons who undertake repairs of femoral hernias must be conversant with the unusual manners the hernias can present in order to overcome diagnostic pitfalls and the delays in management. These are my references. Thank you.
Thank you, Dr. Dalapo, for this presentation. So in our usual manner, we'll be taking comments and questions, or in no particular order. So if you can put your comments in the chat box, that would be fantastic. Otherwise, you can raise your hand, or you can go ahead. I think these two channels, either you comment or question on the chat box, or you raise your hand, so we know who is talking. I wouldn't have a rowdy house. When no hand is up and there's no comment on the chat box, it means that maybe the two options are not favorable. Okay, so if you have anything you want to say or comment, go ahead and talk, but I hope that two people will not be talking at the same time.
Thank you for your presentation. My name is Dr. Abimiko. I don't have a question, but I have a comment. So one of the complications of femoral hernia repair is bleeding, and this can occur when there is damage to normally, like 20% of cases, some patients have accessory obturator artery. So I think it was important for you to have mentioned it in your anatomy, because that artery can actually be injured during surgery, and this will lead to torrential bleeding in the patient. So that's among one of the complications of repair. Thank you.
Thank you.
Yeah, that is not Dr. Bimiko, well done. That shows you, studying in details. I think somebody, okay, from the chat box, sorry. Okay, can you I think somebody is asking for clarification on the laparoscopic femoral hernia repair.
The clarification.
Yes, I think from the chat box.
Okay, so I mentioned that well, I'm not sure I can explain the laparoscopic options properly. So
I just mentioned it the way you mentioned it on your slide. So it's just
okay, so I
common.
mentioned that the common approaches that are used via the laparoscopic approach could be the transabdominal preperitoneal repair or total extraperitoneal repair, and that it's usually indicated for in elective cases or irreducible femoral hernias. It's not advocated for in emergency cases or irreducible hernias.
Yeah, and just to add to that, even in best of centers, most surgeons will not opt in. Laparoscopic or femoral hernia repair is most times is not the first option for most surgeons. You understand, because of the peculiarity of the anatomy of that area. So, but one of the options. You understand. So there are some hernias, okay, or maybe some umbilical, some ventral hernias. You can say, okay, even inguinal, it's easier to develop laparoscopically, although open remain the standard. But for femoral, most surgeons, even in best of hands, are not so eager to go laparoscopic. But it's good. It was mentioned as one of the treatment options for approaches.
Good evening, sir.
Okay, go ahead.
Thank you, Dr. Dolapo, for the presentation. Please, I want to make a contribution. One of the commonest content of the femoral hernia is a small bowel, which I've not heard her emphasize on that. And then secondly, like as you've explained, is mostly found around the groin, but like I think it's good for you to like mention that like it's basically is around the medial aspect of the thigh. So when you said the groin, one could like mistaken it with confuse it with what do you call it, inguinal hernia. So it's good for you to mention that it's mostly found around the thigh, medial aspect of the thigh. Thank you.
Thank you, Dr. Usman. Comments are noted.
Yeah, upper part of the thigh. They say a picture speaks more than 1,000 words. Although she had a very nice picture there, but just like she said, upper part of the involved thigh medially, just below the inguinal ligaments, we were able to see there, and it's always inferiolateral to the pubic tubercle, just like the presenter mentioned.
Thank you, sir.
More comments and questions. Although it's a very straightforward pathology, and the presentation was also straightforward to the point. So I believe it's as clear as it's as crystal clear as water, and there's no area of no gray area or confusion. But if you have, please feel free. I think we still have enough time.
Hello.
Yeah, we can hear you.
Yeah. Good evening. Good evening, sir. Thank you. Yeah. Thank you, Dr. Dolapo, for that very wonderful presentation. I really appreciate your effort. Yeah, like the last speaker said, femoral hernia is always inferiolateral to the pubic tubercle, and inguinal hernia is your media to the inferior to the pubic tubercle. So you have to note that. I have seen your diagrams and they are very self-explanatory, and I appreciate your effort in getting all these diagrams. So like our moderator has said, the self-explanatory, knowing femoral hernia, distinguishing it from inguinal hernia is very important in this pathology. And maybe you will tell us more about inguinal hernia versus femoral hernia in women. Which one is more common in women? And then why is femoral hernia more common in women than in men? That is the question. And then thank you for also bringing up the laparoscopic repairs, the SEP and the SAP, which you mentioned, and even though we don't do it commonly, but it can also be done both in elective and emergency cases, depending uh, on the expertise of the surgeon that is performing the surgery. So, I think you should just let us know. The anatomy is very self-explanatory. Yeah. And then just tell us why is it commoner in women than in men? Why? And then you also talked about bilateral occurrences. Why is it more? Why do we see it bilateral? What happens? Why is it bilateral in female? So we should know. Yeah. And then the repairs, the open repairs that you mentioned, the McKelvey, the Lockwood.
Yeah. Izzy, I can't hear you again. If I'm correct with that voice.
Yes, we lost him. I mean, we stopped hearing.
Okay, so you can start
Can you hear
to
me now?
answer. Oh yeah, we can hear
Yes,
you
we
now.
can hear
Yeah.
you now.
Okay, so which tissues are attached to what in both McKelvey, Rochester, and the Lockwood repairs, so that maybe you can understand it more? Because these are not commonly done repairs. It's not what we do commonly, in our practice. Unlike inguinal hernia repairs that we do every day, so that we can know when we are repairing femoral hernia, what tissue we attach to what in McKelvey, Rochester, and Lockwood repairs, so that everybody will now understand it more. Thank you.
Hello, Izzy. I have to be slightly partial here. Delapo is an ONG resident, and she expected to know the details, but the two previous questions she has to answer. But if you can throw light on that, I think the surgical resident will understand it more. But I'll still give her the opportunity to attempt. So Delapo, if you can answer it, fine. Well, I don't expect you one day to start repairing femoral hernia. Inguinal hernia, fine. You can attempt it, but not femoral hernia. Will you attempt to repair femoral hernia one day, Dalapo,
No, sir.
in O&D?
No,
So if
sir.
you can have answer to it, fine, go ahead and answer. Otherwise, answer the two previous ones, then he will throw more light on that.
Okay, so the reason why, thank you, Dr. Izzy, for your comments and questions. So the reason why femoral hernias are commoner in women than men is because of the first of all, the wider pelvis for the females. Then also the women get pregnant, so that will lead to long-term raised intra-abdominal pressure, which would predispose them to alongside the wider pelvis. And then pregnancy-related laxity of anterior abdominal muscles and ligaments. These are the reasons that these are the things that predispose women to femoral. This is why femoral hernias are commoner in women than men. Then the reason why it's bilateral, I think it's still the same raised intra-abdominal pressure from pregnancy and then weakening and all of that. But I'm not sure. Then for the structures that are attached to, what structure is attached to what in each of the procedures. So for the McEverdis approach, the inguinal ligaments usually attached to the co-joint tendon or the pectineal ligaments. I'm not sure. I can't remember for the lockwood. Thank you.
So Eze, you can go ahead and respond to her
Okay,
comment.
thank you so much. You know, between the inguinal hernia and the femoral hernia, even the inguinal hernia is still commoner in women. When you sample the women, the inguinal hernia is still more common. But when you compare the men to the women, the femoral hernia is more common in women. That is the epidemiology, I believe.
Galabo, you got
Then
that?
for the repair,
Sorry, I didn't hear you.
yes.
In females,
Okay.
do you understand?
In females,
Hernia is still more common
compared to
compared
Okay.
to
inguinal
compared to
hernia is still
femoral
more
hernia.
common in females. Yes,
Okay.
Do you understand?
inguinal hernia
Yeah.
is still more common in females. But then compared to the men, femoral hernia is more common in women than in men.
Yes,
That is when you're talking about that skill that you see in the exam.
yes.
So, yes, but then for the repair, you know, the McKenzie is the superior approach.
Yes,
So when you're looking at the inguinal ligament as the landmark, McKenzie is superior, then the Lexington is the inguinal approach, then the Lockwood is the lower approach, the inferior approach. So you are looking at the pectineal ligament, the inguinal ligament, and the conjoint ligament. So when you are doing a McKenzie repair, then you are looking at the conjoint ligament to the inguinal ligament. Then when you are looking at the Lockwood repair, you are looking at the pectineal ligament to the inguinal ligament. I don't know whether you understand, but maybe when you see it practically, because it is not a common presentation, so nobody will say that he has, you know, a very clear position as that how these things are done. But then that is what is seen in the literature. So when you're doing a McKenzie repair, you're looking at the conjoint ligament to the inguinal ligament. Then, like you're doing in inguinal hernia, but when you're looking at the Lockwood repair, the pectineal ligament to the inguinal ligament, that is the low approach. So that is just it. Then I love the fact that somebody has brought up the fact that those vessels very close to the inguinal canal, sorry, to the femoral canal, can be injured in the process. So you have to look out for that, those complications, bleeding that you can see intra of. So you have to avoid those vessels while you're doing those repairs. Thank you, sir.
Thank you, sir.
Yeah. So I think those comments are noted. But you know, of the three, the easiest approach is actually the Lockwood, the low approach, because you are just going over the hernia, and most times it's one complicated hernia, femoral hernia. So once you reduce it, and if there's a sac, inside the sac, high ligation, then they can just approximate the pectineal ligament to the inguinal ligament. But the transinguinal electrotensive method is actually difficult because you are going to affect the integrity of the inguinal ligament, which most people actually feel that is not really the best, because there's a lot of people do a lot of things there. You can divide it, you can separate it, but at the end, one thing is certain, you are weakening the inguinal ligament and as such also the inguinal canal. So most people don't really favor the transinguinal approach. Of course, the high approach, the McKenzie approach, is mostly favored for emergencies or complicated strangulated femoral hernia, wherein you want to, as a possibility of resection, gives you better access to do whatever you want to do and stuff like that. So those are the things, the factors that guide you in your choice of incision. Do you understand? It's not like you have all the three always. No. The instances it has to be high. The instances is best to go low. Transinguinal is neither here nor there. Most people took it as a gray area. You understand? If you're not so familiar with either of those two, you can just okay, let me put the adverse effect that it weakens inguinal canal at the end of the procedure. So I don't know. There's still more room for contributions and comments. More comments, questions. So it has been a very wonderful and fruitful discussion. So let's keep it coming. Although it's a straightforward thing, the presenter did a very good job with pictures, and that's quite commendable. I hope we'll continue in this pathway. Pictures speak 1,000 words. You understand? So with the pictures, it makes the presentation interesting, and you have few things to explain or talk about. Okay, since the room is becoming as silent as the grave, I want to thank everyone. Maybe you're all begin to feel sleepy now. Thank you for being part of this August presentation, although we are in October. And we hope that we still have more of this subsequently by next week. So whoever is presenting should make his or her own presentation better than this. So I really appreciate all the comments, all the questions, they are all valid. The presenter well done, and there's always room for improvement. So you can also improve on this. So we hope to have your slides subsequently posted on the WhatsApp group for that people who may have missed the presentation also to partake of this presentation. Thank you so much and have a wonderful night rest.
Thank you, Dr. Hello, Chief.
Okay, yeah. Okay, yeah, the Bashiri, okay.
Yes, a message from Prof. Yahweh.
Okay.
Yes, he sent his message and that he traveled to Ghana for the fellowship exams of the African College of Surgeons. So that's why he could not join us due to the preparations for the exam and also the part of the examiners. So he sends his apology that subsequently he's going to be with us and share his own comments. And thank you very much, the presenter. You did a very good job. And as the moderator, our chief said, being an ONG resident, for this presentation, you really did well. Just before we go, I just want to add one or two comments on femoral hernia, that every house officer, resident, okay, senior registrar, once ever you see an elderly woman presenting with intestinal obstruction, okay, especially obstruction that is similar or obstruction with features of SBO, small bowel obstruction, don't forget to look at the upper medial aspect of the thigh. Remember this, anytime you see an elderly woman presenting with features of intestinal obstruction, you are on call, especially if she has features of intestinal obstruction and there is no gross distension of the abdomen. Don't forget to examine the upper medial aspect of the thigh. You can see that as a differential diagnosis. It's a differential diagnosis. Perhaps all the femoral hernias I saw during my residency training, they were all elderly women, and they presented with a lump in the upper medial aspect of the thigh. that looks like an enlarged lymph node. So don't forget to examine such if you see an LDL for all the reasons she gave, for the risk factor, weakness of that part. Okay, and several reasons. Then the second thing I want to also draw our attention is regarding the repair. If you remember the relation she described, the vein, okay, and the canal, vein, artery, nerve, okay? Don't forget the nerve, the vein is just adjacent to the canal. So sometimes during the repair, when you injure the vein, you see blood gushing, don't panic. What you do, just apply firm and consistent pressure, okay, and wait for some time, give it time, okay? When you injure that vein that is just adjacent to the canal, don't panic. Put a firm and persistent pressure and wait, give it time, okay? Most of the time, the bleeding will stop. And lastly, for the procedure, this message is for mainly surgical residents and the senior registrars. When you are describing a procedure in a presentation like this, you should have images that is showing the anatomy of what is opposed. Because when you have a mental picture of what is being done, you will always remember. As Chief says, a picture is more than 1,000 words. Okay, so the contributions that AZ made are very relevant, but such such contributions, okay, such descriptions are better with images for better understanding when you are describing a procedure. So by and large, Dr. Dolapo, you did well. It's a very interesting presentation. We thank you and also thank the presenter and the moderator for sparing his time to moderate and share knowledge with us. Thank you very much. Thank you everyone for participating.
Thank you, sir.
Thank you, sir.
Okay, I think we can stop here. The next presentation next week is going to be on a journal club presentation, okay? And the moderator is going to be Dr. Dades. So we are going to share the journal on the platform so that everybody goes through, and this is more important for you to know how to make research. Okay, that is the significance of a journal club presentation, and we are going to discuss in detail how to review a journal, and when you are preparing for a research, you know the steps to follow. So thank you all, and let's have a good night rest.